All right, I think we can go ahead and get started. Hi, everyone. My name is Stefa Dragoon. I'm the Rural Population Health Program Manager at the Oregon Office of Rural Health. Welcome to the second of six in the Population Health webinar series. We're really grateful that you all could be here. Today's webinar is digging into community health data presented by James McCormick of OHSU. Thank you for being here, James. So this webinar series is designed to establish a common understanding of population health and where we can go from here. Population health data and record keeping and electronic health records is really an essential piece to the puzzle of improving population health. Population health and health equity have grown in focus over the years for many reasons, including the realization that the high level of healthcare spending in the US is just not producing the value we'd like to see in terms of the overall impact on health. The healthcare industry is going through some profound changes in financing and service delivery as it shifts from a financial system that pays based on volume to one that's based on value. Today, rural healthcare organizations face the challenge of remaining viable under current payment systems while also preparing for new value-based payment systems that are being adopted in various forms across the country. So this webinar series is really designed to learn together and have some of those conversations about how to approach population health moving forward. So I'm going to move. So here's the full series. Besides the first one that we had at the beginning of the month. So you can visit the website, which I'll put in the chat to register. You do have to register for each of them individually. I'll put that in the chat for you all. I also wanted to let you know about the Rural Population Health Grant Program that our office is administering. The request for proposals is going to be released on June 1st with a July 7th deadline. And this program goes to support critical access hospitals and provider-based RHCs with addressing specific population health needs in their communities. And I will put that in the chat as well. Just one moment. All right. So these webinars are also eligible for continuing education credits. So you can, I'm putting a lot in the chat, but you can, after the webinar, please feel free to fill out this survey to receive your CEUs for this event. And then moving on, James does not have any conflicts to disclose. Before we get started, I just wanted to ask everyone to please mute yourselves during the duration of the webinar. We'll have a Q&A at the end of the presentation where we can address any questions that were placed in the chat. You can also have an opportunity to, you can click the raise hand button and unmute yourself and ask your question live as well. And just so you know, these webinars, the presentation slides, and the recording will be placed on our website, which was the first link I put in the chat. Awesome. And with that, I am really happy to introduce our speaker. James McCormick is a clinical informaticist who is,
Yay.
yeah, did I do it right?
You did.
Practiced, who received his PhD from OHSU after a long career as a health IT consultant. He is currently a senior research associate with the Oregon Rural Practice Research Network, otherwise known as ORPRN, and an instructor and affiliate faculty member in the Department of Medical Informatics at OHSU. As a participant in several projects and collaborations with ORPRN and OHA, James has developed extensive experiences using EHR technology to capture, use, and acquire data from screening assessments for behavioral and social needs, and has assisted clinics with associated EHR configuration, workflows, and analytics. Welcome, James.
Well,
Thank you so
hi.
much for being here. I'll let you take it away.
Well, it's a pleasure. Next slide, please. So we have so much to cover, and I'm really, really pleased to see so many familiar names attending today. So a lot of you I've already worked with trying to extract social determinants data from your EHRs, and we start out thinking, well, how hard could this be, right? We've got this electronic data source. We've got all these tools to pull data. Why is this so hard? And I think a lot of this today is going to sound familiar for those of you doing it. It is hard. It's hard for some good reasons, but I hope what you'll hear today will give you some hope that the standards for data are really emerging quite quickly, that vendors are not only adopting the standards, but they're implementing tools for social determinants. So this has become a very high priority, not just from a policy standpoint, but I think the EHR vendors have been paying attention and we're seeing a lot better support in these systems. One of the big challenges in a talk like this is making it generalizable and relevant to everybody because not only is every electronic health record different, EHR, but every implementation of EHR can be different. So if you've seen one Epic, you've seen one Epic, as they say. I'm not sure who said that, but it's kind of a cliche at this point, but it's true. And if I work with OHSU Epic, I see different data elements than if I work with an OCHN Epic. So I think the variation in the systems that we're working with as data sources is not just a problem for social determinants, but has been brought up again and again in any quality improvement initiative or population health initiative. The data is just so variable and so scattered, it makes doing the science on it very, very difficult. But we know that, and again, we're making progress on trying to solve the root causes of nomenclatures and other things. And we'll talk about that. Next slide, please. So I am not going to go through social determinants because everyone here knows what they are. I think the bottom line, next slide, please, is that we make some assumptions for the purpose of the presentation. So these are all a little dodgy, but if you notice the little chat box at the bottom, that is not a live chat box. That's basically a prompt. Feel free to drop in a comment if you agree, disagree, or have any questions as we go. I would like this to be interactive, and I am watching the chat box as I talk. So if you see me glancing over to the right, that's what that is. But there's some assumptions that we're making today just to sort of get into the data part of the discussion. First of all, is that individual health is impacted by social and behavioral factors. I don't think I doubt anyone would disagree with that, but that's an assumption we're making today. Next, rural healthcare providers not only do, but will do assessments for social needs. So this is already happening. For the Medicaid program in Oregon, we see an incentive metric all about this. So the pressure is there to do the screening in primary care. And even if there's some resistance, mainly due to the lack of capacity, frankly, this is coming. And I think, again, I'd be curious if we would all agree on that, or if anyone feels strongly that maybe primary care is not the place for this to happen. But I'm going to go on the assumption that not only is it, but it's happening. And then the third one is that access to patient level data is really critical for high quality and equitable care. And we can't leave out equitable care because so much of this data might be coming from patients with the highest level of need. So it's important not only collect it, but to be able to do something with it and take action based on identified needs. So those are my three assumptions, and I hope everyone will agree with those three. But again, feel free to disagree. And I think that would be just as interesting if somebody feels maybe these aren't good assumptions to make. But those are the ones I'm making. We also named the topic EHR, and I understand that there are multiple data sources out there for social determinants data, and there are even more coming. So we will, unless we have time at the end, which I somehow doubt we won't really talk about non-EHR data sources. If we do have time, I'm happy to dive into that. But I think each of these would be a topic for its own session, talking about community information exchanges like Unite Us, Aunt Bertha, which is now, I think, Cry for Help. No, I Ask for Help. I forgot what they renamed, but the former Aunt Bertha. But platforms that are specifically dedicated to supporting screening and providing resources for social need, but also health information exchanges that may have started out for clinical purposes that have kind of evolved into the behavioral and social space. And Reliance Health Information Exchange is a good example of that, where they have incorporated social needs data and even built alerts and notifications based on the data they're getting from electronic health records. So we're seeing a lot of activity outside of the EHR space in supporting these use cases. I'm not really going to have time to talk about those today, so I'm really going to focus on EHRs. And then finally, another kind of interesting topic for me is databases with community level social factors. So in doing research for this, I came across the ARC database that shows regional social factors by a variety of geographic and demographic features. And it's always interesting to combine those data about the community with data on your patient population when doing population health. So those databases are out there and they're getting better. We're really not going to talk about those today. So next slide, please. So the types of social determinants data, again, we could really have a lot of discussion. Help.org. Thank you, Crystal. I liked Aunt Bertha. That was very cool. So types of social determinants data. Well, first of all, an EHR can represent any kind of data, really. I mean, voice, imaging, fine. But the ones we really care about to support use cases in dealing with social need are, of course, individual demographics, including race, ethnicity, and disability, or Real D. Eligibility for screening is important. Have they had a screening within the last year, for example, is important to be able to target patients that are overdue for screening. Visits for encounters relevant to screening. So if I'm actually delivering social or behavioral interventions within the clinic, it's important to have those documented in a way that we can retrieve them. And one example would be referrals. So, well, I'll skip over that. So screening tools used, this is super important because there, as we'll talk about, there's a very large number of screening tools available, and there's a smaller set that OHA has identified as, quote, approved for the purposes of the CCO metric. But that's still a long list. So knowing what screening tool was used, what responses were collected, how those were interpreted, and what conclusions were made is also important. And that's a heavy lift for an electronic health record. Those of you who have kind of lived in this world a long time know that depression screening seems pretty straightforward, collecting a PHQ-2 or a PHQ-9, but what about collecting the interpretation? What about collecting any intervention that was done based on a positive score for depression? All of those can be tricky when you're dealing with EHR data. Actions taken is also tricky with social determinants data, largely because at least now a lot of those interventions are done outside of the clinic or they're done by community health providers that wouldn't be what we'd consider a traditional medical provider. So when I think of a referral to an outside clinical specialist, I kind of think of an electronic workflow where I create an electronic referral, they get the electronic referral, and if I'm really lucky, I get an electronic closed loop notification and maybe a report back from the specialist. That's all well and good. And we're not even doing that well with clinical referrals. We're so far away from that with behavioral and social need referrals that it's almost uh, well, it's a heavy lift, let's put it that way, to try to rely on the EHR as a good source for closing the loop on community care. We're just not there. So in a lot of cases, we're really dependent on outside data sources to know what was actually done in response to an identified social need. So that gets into requests for community services, but just as important, feedback from those services that those requests were received and those services were delivered. That's a really tough one. Administrative coding is important. And when we talk about a glucose level, you're going to probably bill for a glucose level. So we could rely on claims data pretty heavily for things like lab tests, for things that are billable. ESPERT was originally, which is the alcohol and drug risk screening, was originally a CCO metric that used billing data. And what they realized is there it was so inconsistent, it probably wasn't a good proxy for whether screening was being done. So as many of you know, they shifted to an EHR-based measure that actually looks at the screening data itself. The same thing really happens with social determinants. And we'll talk a little bit about the CCO metric and for social determinants. And when that evolved, there was a lot of discussion about whether it should be a claims-based measure. Why? Because that's easy data to get, or whether Z codes, and more on that, much more on that later, are a reliable way to assess whether people are getting screened and whether those screenings are identifying needs and whether those data can be used. So again, administrative coding is still super important, and I'll ask a question a bit later on a chat prompt about whether you're using Z codes because I'm kind of curious to hear what you have to say. And then finally, the kind of really the tough nut to crack for informatics is the clinician notes and narrative. A lot of social need data is going into narrative, and while the technology is there to do AI and natural language processing and all this great stuff to try to mine that data, in my world, which is rural clinics, usually independent small clinics, they don't have the resources or technology to do that fancy stuff. So anything from my perspective that's hidden in notes and narrative is almost lost data. Again, that's going to change. The tools are getting better. The EHR vendors are incorporating better and better methods for mining narrative data. But from my perspective, we're just not there yet in small clinics. So I hope to see that in the future. Next slide, please. So screening assessments, I mentioned that there's a whole zoo of screening assessments available. The slide on your left, the picture on your left is actually the most recent from March 23rd, approved screening tool list for the OHA incentive metric. And for those of you who aren't aware of that, for rural health providers, I'm sure you all are, but the Medicaid program in Oregon, run by the Oregon Health Authority, provides different incentive metrics to assess how clinics that see Medicaid patients are doing. And one of those metrics, a new one, is for assessing social needs and also reactions of social needs. So we'll talk more about the actual metric, but the bottom line is the list on the left, and this is just a partial list, I think I cut it off towards the bottom, is showing you which ones they have approved for which domains of social need. And those three domains are the ones that they've chosen to focus on for their incentive metric. Clearly, as we look at the prepare, there are actually multiple other social domains that could be collected in a clinical or behavioral setting. So this is just food, housing, and transportation are not the only types of data, but because so much of our focus right now is on meeting that CCO metric, I'm probably going to focus more on those today, but there are clearly others. But the most popular screening method is really prepare, and I think we see that everywhere. And to the point, as you'll see in a minute, where the EHR vendors have done a pretty good job of integrating the prepare screener as structured data into their EHRs and actually created sort of canned or pre-built screeners for the most part. Now, not all EHR vendors have done that, but the big ones for the most part have. So prepare is the other one. Next slide. And then we get kind of a whole laundry list of other ones. AAFP is one that we see a lot, which is again, a different variation of that, but it's also very popular. And then the one on the right, I stole this from a presentation from Bighorn Valley, and I don't know much more about this, but I've heard on a lot of our work group calls that people are using pictorial screening assessment tools. And I think I'm looking at one of the attendees, and I think you're one of them. I should have gotten a copy of yours. But bottom line is that to speed up screening on the front end using a pictorial data collection tool where the client or the patient can circle any needs that they have. And then at the end of the day, that has to be translated into something an EHR can understand, which is check boxes, yes, no. Next slide. So we see that there's a bunch of different ways that we can collect social needs data. Again, there's a whole list of potential assessments. And I'm curious if you wouldn't mind popping in the chat, anyone who's using something other than the prepare or someone using a pictorial assessment, at least for the initial screening to give to the patient. Again, we're seeing that in our technical assistance work, but that's actually a fairly small group. So moving into EHRs now, which is kind of our main focus. I mentioned that EHRs are doing a better job of supporting this. I'll probably get in trouble for using an Epic screenshot, although I did pull this from publicly available presentations. So that's my defense here. But a recent, well, semi-recent 2018 article by NORC, or white paper by NORC, actually looked at the capabilities of commercial EHRs, the top vendors, to see if they supported social determinants. And they broke it down into screening, ability for doing population health and analytics, the ability to manage referral and care transitions, and deep analytics for reporting. And you can see there's a little graph there that kind of summarizes their data. I've included a link in the material, and hopefully I've cited everything I use here with links, so anyone interested in really diving in can. I found this really kind of illuminating. It's always tricky when you're surveying vendors because I worked in the vendor world for 13 years, actually, for Cerner back in the day, and I know that vendors, when they respond to a survey like this, will always put a happy face on it. Can you do X? Of course we can. So these types of surveys are always tricky, and your mileage may vary. The other thing, and I touched on this earlier, is there's so much variation, not only between EHRs, but implementation of EHRs, that even if the vendor can provide certain functionality, it may not be there for you in your setting, either because it isn't turned on, a certain module wasn't licensed. There's all sorts of reasons that these features and functions may not work out of the box the way the vendor expects them to. But bottom line is certainly Epic does have the ability to capture, prepare a structured data The top screenshot shows that. The other neat thing, and Ochin gets a lot of credit for working with Epic on this, is developing what I call the cheese wheel. I guess there are better names for that, but the social determinants wheel. That's a way of visualizing any social needs that have been identified for the patient. I haven't seen anything like that in other EHRs. Again, chime in on the chat if you've seen this type of visual representation for social needs data outside of Epic. But I think this is kind of neat and seems to me to be kind of a best practice. Now, the catch is that as with any EHR tool, it's dependent on the underlying data to support it. So I've seen people turn this on, look at it, and get disappointed that it's really not telling them anything. And that's either because they're not following the workflows necessary to populate those data, which is a very common problem, or they're not implementing the screeners consistently enough to really make that a usable tool. And we'll get into data quality because that really is kind of the heart of the challenges we run into. So Kim, I noticed you mentioned Pictorial. You might be the one I'm thinking of that mentioned it on the work group. Love to see your copy of that. Okay, next slide, please. So a little bit more on vendors. This is Athena Health's version of the Prepare, and on the right is eClinicalWorks version of Prepare. Now, one interesting thing is I've noticed, and I'm not going to call any vendors out, but most vendors do offer the Prepare and other assessments for free. One of them, however, does charge for that. Is something called, well, if I say that word, you'll know who the vendor is. So again, many clinics may not have access to a canned prepare in that vendor system if they choose not to buy it, but there are other methods for collecting the data. So if you're in that category and you know who I'm talking about, you can still build structured data elements to capture the contents of a prepare questionnaire. It's not going to work with the canned reports and other neat stuff, but it will allow you to collect the data without having to purchase additional module. Next slide, please. So if any of you are using an EHR that either, we don't want to name out EHRs and do any naming and shaming. Honestly, I might be doing that by implication, and if I am, I apologize. But again, I'd be interested to see if you feel that your EHR, without naming them, is doing a good or bad job for supporting your social determinants efforts. So let's talk about data. Representation of data. This is as an informaticist or informatician or informaticite or whatever I'm calling myself today. The representation is important. And as some of you who are really into this know, that there's been a lot of efforts to standardize clinical data. And the ONC Office of the National Coordinator for Health IT has basically funded this effort to basically standardize everything in a medical record, or everything, quote, important as a minimum data set of clinical data. There's been a lot of effort with social determinants to include that, and they did. So I'll talk about another initiative in just a moment, but USCDI is way ahead of the curve in including social determinants health elements. And so if you were to create an electronic health record from the ground up today and want to use a standardized data model, this is probably the one you would want to use. And my point is it does include a schema for managing social determinants of health. Now, that's all well and good, but to my knowledge, there is no commercial electronic health record out there today that's based on the USCDI model. So where this really comes into play is when data are extracted from an EHR and they're mapped to this standard schema for other purposes. So in theory, it may someday be possible to click the USCDI button, export in, you know, rhubarb EHR, and be able to get these standardized map data elements, but we're not quite there yet. But I think it's hopeful that there's so much effort going into trying to create the nomenclatures and the schemas to really build the foundation for managing uh, um, standards for social determinants data. So next slide. So I mentioned somebody really being instrumental in sort of pushing those into the USCDI, and that would be the Gravity Project. Again, this is a really good one to know about if you're in the weeds with nomenclature. So some of you may know about value sets, but when somebody publishes a clinical quality measure, and there are other uses, but primarily that's the big one I use, there's a value set out there that says this is what a diagnosis for diabetes looks like for the purposes of quality measurement, or this is what a food insecurity diagnosis looks like as represented by a LOINC code or represented by an ICD code or a Z code. So where are all of those code lists? They live in either the Gravity Project's own tools or in the Value Set Authority, which is kind of the grand registry in the sky where these value sets live. I mention this because in a lot of analytics efforts, the first question is, what do I mean by food insecurity? What do I mean by the patient has uh, expressed a gender identity? Well, to get to that from a data standpoint, I really need to be able to not only use standard code sets, but I need to know that those code sets are being accurately represented in the electronic health record. And we're getting better at that. So I mention this here because the CCO metric explicitly references these value sets, either accessed through value set authority, and there are links in here. Well, actually, that's a screenshot, so you'd actually have to go to the Gravity Project page that you see. But bottom line, if you're wondering what codes do I use for SNOMED to identify food insecurity, there's a table for that. Next slide. So I kind of touched on the ones that the OHA metric uses, and this is right out of the most recent specification, which is the final specification for the social determinant screening. I should point out right now that there are two pieces to that metric, and the first one is what went into effect this year, and that is for infrastructure for collecting this data within the regions, and that is largely on the shoulders of the CCO, is to work with their clinics and make sure that they have the education, the infrastructure, the knowledge, the desire, all of that is basically build up the capability to collect data. The second part, which if I'm not wrong, goes into effect next year, is actually more of a traditional quality metric where it's looking at data, not only from the EHR, but those other data sources I mentioned, to be able to assess how often screenings are being given, what the outcomes of those screenings are, and then most challenging, at least for most of us, is whether some form of intervention or referral for services was done based on a positive finding on those screenings. So all that is super tough, but as usual, OHA has done a really good job of specifying how that metric needs to look. So this is actually the 2024 half of the metric, and it involves pulling data out of information systems like EHRs. Now, Loink is an interesting beast because I was a lab tech originally, and so I worked with Loink for a long time in identifying lab tests and lab results. Loink has been expanded over the years to include other domains, including most recently social determinants of health. So many of you may be familiar with Loink coding for lab, but it also does have a role to play. I will say that many EHRs currently do not map their social determinant concepts to Loink coding. So that's something that they have to go do. Some of them will link it to SNOMED coding. Others will use ICD-Z coding, and then yet even more will require users to manually code based on the findings of screening. And that will get us into Z codes, which I think we'll talk about next. So again, this is kind of a fun topic for me, but it kind of is pretty boring for everyone else. It is important, though, to have bookmarks to these references when you're doing data analysis, is to know where to look. How do I know what transportation needs look like when they're represented as electronic data? And hopefully they look something like this. Next slide, please. Z codes. Z codes are fun, and I mentioned the challenges that the SBIRT or the alcohol and drug risk screening had using billing codes as a proxy for delivery of screening because of because of reasons, lots of reasons. Well, again, the earlier discussions for social determinants looked at Z codes, which I think most of you know, but are special ICD codes that are used for non-quote clinical findings. And these can be used as surveillance codes for things like, remember the one key question for asking about a desire for pregnancy? That was represented using Z codes. But here there's a heavy reliance of payers to use claims associated Z codes to identify and represent social need. So as you can see on this list from the OPCA, and by the way, they've done some amazing work with the National Association for Community Health Centers in basically creating help guides and white papers and stuff like this and kind of work aids like this to help the analyst. Thank you, OPCA, for anyone's on the call. Bottom line, though, is where do these Z codes come from? Rarely they are automatically applied to the patient record by the findings of the screening. In the ideal world, and some EHRs can do this, you would identify a transportation need and magically a Z code would appear on the encounter. That would be great. Some EHRs can do this, but for the majority they don't, which means we're either relying on a human, possibly a clinician, somebody doing the screening like a medical assistant, or maybe back office personnel who are reviewing the chart for the claim to manually apply these Z codes based on the findings in the screening. This is a huge challenge. So I have a chat prompt here, which is, are any of you using Z codes now? And if you are those applied by clinicians or by back office personnel? Or best case, does your EHR code those automatically? The reason this is so important, though, is this does go out with the claim. The payers have access to those claims data, and they're heavily dependent on them, not only for identifying social needs, which many payers are doing now, but also the ability to adjust risk levels. So for Medicare and Medicare Advantage, being able to use social needs as a way of adjusting clinical risk is becoming more important. And I think we'll see that more with value-based payment programs with commercial payers wanting to use social risk as a way of adjusting risk. So these are super duper important. And I think there's often assumption in when people develop quality measures that these data are magically available. And I'll tell you that there was a lot of discussion within OHA whether Z-scores, asking for Z-scores from clinics is feasible. And at the end of the day, the conclusion was yes, it is, but there's work to be done on that. Next slide. So extracting social determinants from EHRs, this is super duper tough. And again, I'm using some screenshots here, probably without permission, but bottom line, if you're lucky, your EHR does provide canned reports. eClinicalWorks, if you license their Prepare, includes a set of EBO reports that can pull data from that. OCHIN has a set of canned reports for social determinants of health that pull from their screeners. And on the right, the uniform your UDS system for community health centers. They've already been reporting this as part of their UDS reporting. So most systems that serve the FQHC community will have canned reports for those. But again, these reports are really only as good as the underlying data. Next slide, please. So this is so hard, and I realize there's a lot going on here. Um, so a project that I was part of with ARC was developing a handbook for practice facilitators to help with extracting data from EHRs. So these tables are from that. I really recommend this as a resource, not only because I was one of the authors, but because these are questions that always come up when I work with people doing analytics, especially small clinics that either don't have the training or the resources to go deep into data, even if the EHR vendor provides the tools to go get it. So I'm going to go through this pretty quickly, but the bottom line is there are really 5 ways of getting data out of an EHR. The first one is using pre-built reports and audits. I touched on those. Your EHR may simply not support those. Option 2 is using flexible registry searches or patient lists. Most EHRs do have the ability to do kind of a semi-customized patient list. Show me all the patients with ICD-9X or ICD-10X seen in the last year for a well woman visit who had a rhubarb level. And then I can get a list of those patients, dump them to a spreadsheet, and go on with that. So it's not ideal, and the filter and the extraction limits are going to vary by vendor, but that is definitely a place to look before you go to one of the other options. Well, option 3, dashboards and quality measures. Well, if I'm looking at hypertension, I know there's a MIPS measure for hypertension control, and odds are my EHR supports it. I can pull a list and maybe run patient level gap lists from that quality measure from my MIPS dashboard. That's great. We're in early days for social determinants, and while there are several proposed metrics for measuring performance data on social needs screening and a follow-up, OHA had to develop their own metric and did. So if you look at the NQF website, you'll see that several proposed ones, but nothing's been finalized. So we're very early on in having, quote, standard quality metrics for social need. They're coming. But even after standardized, vendors are going to have to implement and certify them. So we're a long way from option 3 for social needs. Next slide, please. My personal favorite, custom reports and database queries. So I love doing this. Uh, the trick is, though, I have to have tools that allow me access to the backend database. Not all EHR vendors provide that. Second, I have to have the expertise to be able to write structured query language, or worse yet, proprietary queries in some EHR specific reporting tool. This is super tough. And while this would be my last option, there's actually a worst option here, but it is one that we end up using. More on that in a second. So again, the thing to know about doing custom reports is how difficult it is to locate the data in the backend database and then to clean and standardize it. So honestly, the biggest challenge I find in working with these data is not so much sucking it out of the EHR. I mean, I can run a report in Epic and pull the flow sheet for the prepare and get all the raw data, but it's also standardizing it and making sure that the data makes sense. So data quality is super important. I'll talk about that actually on its own in just a minute. But let's talk about the last one, kind of the elephant in the room. Or I just heard the white elephant in the room, which I like even better. Chart audits. Honestly, this is the gold standard. And given all of the variability we have in EHRs and the way that data can be represented, even in the same clinic, often this is where we end up. And there's no shame in having to do chart audits. Chart audits can be combined with other types of reports. So for example, I could create a custom report that selects candidates for a chart audit and really kind of streamline the work effort needed to actually go in and abstract data by looking at the charts themselves. Epic, I'll call them out, are really good about this because if I create a custom report in Epic, I can look down at the bottom and actually pull data from the chart and click down through the rows of the report and see detailed data, pretty much anything that I want to see, including results of screening. So I can use that as kind of a interactive way of I don't want to say automating chart audits, but basically presenting candidates in a way that I can very quickly abstract the data. So I'm curious, another chat prompt, are any of you having to resort to chart audits to get to your social determinants data? Or for the most part, do the other four options work for getting the data that you need? Next slide, please. So ensuring quality, I cannot stress how important this is, and it's something that's really overlooked. There are so many assumptions that we make about data once we see it in a spreadsheet. So once your analyst has extracted it, you have this great, beautiful spreadsheet with the data columns, and you're looking at it, and you see a bunch of nulls. You have to ask some questions about that. Is it complete? Are people using the same workflows to populate those data? Often we'll see people scan in a social needs screener, but forget to put those into the structured data field. I'm not going to see those data represented in an extract. Correctness. Again, especially in early efforts to implement social needs, a lot of that might be free text data. Even free text data put into a structured data field. And an epic example would be a smart data element. As you know, I can have a smart data element, which is reportable, but I can put free text in a smart data element. So if I'm relying on that free text to represent the findings of a screen, that's going to be very difficult to mine. And without natural language processing or sort of one-to-one mapping of text strings, it's very difficult to do. So correctness, concordance is the next one, which is there agreement? This happens all the time. If I'm relying on Z codes, are those Z codes concordant with the screening data itself that I'm capturing? And typically the answer is no. Either the Z code gets put in based on clinical findings and not based on the screener, or the screener is skipped entirely. So I don't have concordant data between answering yes to a question in the screener and representing a Z code on the encounter, if that makes sense. So when evaluating data, concordance is another metric that is important to look at to see, does my data really, is it internally consistent? Well, currency, that's a big one. And with lab results, I see this more and more as interoperability gets better, and I start to receive structured lab results from not from labs, but from other EHRs. Those might be historical lab results. They might not be current. So we're not seeing that quite yet with social needs data, but that's probably coming. So knowing, is this the most recent data element? And I see this a lot when people are using multiple systems to do their screening. I touched on the Community Information Exchange, Unite Us, Aunt Bertha. The CCOs are deploying this now to assist with screening across the state. And if those screeners are living in Unite Us, but some of the other screeners are being done in the EHR, I'm not only going to have incomplete data, but the most current data may live somewhere else and I may not be able to see it. And finally, plausibility. Is it likely that the patient has a home address in their demographics but are listed as homeless? Well, there might be administrative reasons for doing this. Maybe it forces me to put in a result in the billing system. I don't know. But again, being able to sort of link and compare those different data elements is important. And in the handbook, and thank you so much for linking that, Sarah, linking the handbook. I know ARC is very proud of that, and it was a pleasure to work on it. So, having said that, though, in the handbook we recommend 4 different ways of looking at data. Follow the data, and that's really important to be able to take it from the screening workflows itself, looking at the physical piece of paper that you've given the patient, or the portal screen that they're filling out their screener on, and taking those data elements all the way through to the electronic representation in the EHR, and if you're doing custom reports, all the way to the back end to see if the questionnaire on paper with the responses on paper is corresponding to what's in the actual bits and bytes database. And this happens a lot. And that's really part of the reason we have to do so much data cleanup. I see this a lot with the alcohol risk. Is sometimes people will reword the screening questions, which is probably not a great idea, on their paper screening, and again, for good reason, or they'll maybe change some of the responses, and those responses won't correlate exactly on the back end data elements. So that's a little tricky. So follow the data, make sure what's on the front end is what's represented on the back end. Look for red flags, really looking for any of those data quality issues we talked about, and comparing with the gold standard. If you are lucky enough to have third-party data, either from the Community Information Exchange, Unite Us, for screening data that you can compare with what's in your EHR, that's a great way of doing it, assuming that they're going to be, if they're apples and apples. And then the best way is to ask for a gut check. I can't tell you how many times it's happened where you talk to one of the behavioral health consultants or one of the community health consultants, and they'll say, no, there's no way that data is right. We're doing a lot more screening than that. Okay, then why aren't I seeing that in the data? And there's usually a good reason. Well, we're scanning them. I'm not seeing the scan data. Or the MA isn't putting them in the right, quote, the right fields. Another one I see all the time in Athena, as a heads up, is that Athena allows you, originally would have you put this stuff under social history. So they had a lot of canned fields for social needs under their social history that you could use, and people did use them. And you could create your own. So that was kind of the prime place to put this stuff. Then along comes the prepare screener. So now the same data can actually live in multiple places within the same EHR, and in many cases live in both. And are those going to be consistent? Well, if I'm doing a prepare screener, I may mentally no longer be checking those boxes in the social history. So again, we get into issues of completeness and concordance. Are those really comparable? Should I be relying on one or both? And what we see is that over time, as people transition to using the more, I guess, modern screening, they sort of stop using the older screening methods because nobody wants to do dual data entry. And if they're putting screeners in Unite Us, they're probably going to stop putting them in the EHR. So that's something to really keep in mind, that these data factors do change over time. So if I pull a report covering a year measurement period, I need to be very aware that the workflows for reporting have likely changed a lot during the period those data were collected, and I need to be able to accommodate that. So again, there's so much change going on in this area that you're going to see your data quality change over time, even within the same data set. Next slide, please. So common challenges, I've really kind of touched on all these, but by way of summary, these are the ones that I know about, and I invite you to put in the chat anything I've missed here. But first of all, poor data quality. In my little brain, this is pretty much covers all of them. every one of these that I'm going to talk about kind of contribute to poor data quality. So we'll just leave that alone. Missing or unconfigured EHR features. This is a big one. I touched on the fact that some vendors may not provide the prepare out of the box, so it may just not be there. Maybe it hasn't been turned on. More commonly, what I'll see is that the functionality is there, but it has to be configured to be used. A good example is when uh, canned screeners are provided, but they're not mapped to local concepts within the EHR. Sometimes the clinic actually has to do that last piece. And that's one of the reasons why the canned quality measures often don't look like what you think they should, is you miss that step of actually mapping the vendor concepts to the local concepts so that those measures can work. And the same thing's true here. If I have canned features by the vendor, I need to make sure that they're fully configured and that the workflows, which is the next item, I'm using follow the happy path that the vendor intended. And this is another one. Every clinic is different. Workflows vary for very good reasons. I did my dissertation on workflow variations, and I was surprised at all of the good reasons people have for not following vendor recommendations. There are very good reasons for not doing that. Having said that, though, since we're looking at data and we're looking at assumptions the vendor is making about how you're representing your data, it is important to at least be aware what the vendor expects in terms of workflow. And if you're varying from those workflows, make sure that you either have a plan B for collecting data or that you're able to adjust the data after extracting it by mapping it and doing other tricks on it. Use of processes or technology other than the EHR. I touched on this with, the growing use of Unitas or other CIEs, even Reliance. I didn't mention uh, Collective Medical. Collective Medical, or EDIE, EDIE, was originally designed to notify clinics of ER visits and inpatient visits, and it does that quite well. But they've expanded their use cases to look for diagnoses of social needs and then also create cohorts and notifications. So some clinics may or will be using Collective as a means for notifying them that a emergency room or hospital has identified a social need in the same way that they can do it with alcohol or drug risk factors. Having said that, that's not in your EHR. So a lot of this stuff is bypassing the EHR. And as we use these CIEs and HIEs more to collect data and to manage referrals and service requests, until we get these systems integrated, that's going to be a lot of missing data. And we can't just rely on the EHR to tell us what happened after, for example, a service request was put in for food assistance. And then finally, insufficient tools, resources, and expertise. Got to mention that one. And again, clinics have a lot going on right now. We found very clearly that even though the CCO metric had been around for a while for alcohol and drug risk, some clinics simply either weren't doing it or weren't reporting the metric because it wasn't a high priority for a lot of reasons. So there are going to be clinics that this isn't a priority, or they don't, it just isn't a high enough priority to devote their scarce resources for IT and analytics. So this is where outside resources come in, and we'll talk about technical assistance in just a minute. So I see in the chat, Ochin, yeah, Ochin's done a really good job. And I think if you do a search for EHRs and social need, you're going to find a lot of Ochin papers. I was just reading one of them, in fact, where they look at EHR capabilities. So Rachel Gold and her team, um, Deb Cohen from OHSU, all have done an amazing work in there. So I really encourage, if you want to read about the experience of others struggling with the same things you are, there is stuff in the literature, and Ochin has been a big factor. Okay, so next slide, please. So use case, rates of social determinant screening. This is right out of the metric, and the metric was, I think, recently updated. I forgot the date. So there is a final metric now for the CCO incentive measure. This is it. We won't go through in detail, but I imagine you're all probably either familiar with this or getting familiar. Remember, though, that the EHR portion of the metric doesn't hit until next year. I imagine the CCOs, and if there's anyone from a CCO that can chime in on this, are going to be sort of paving the way for this. Including possibly asking for some of this data prior to 2024. So CCOs chime in on what your plans are and how soon the clinics might be seeing requests for these data. But bottom line is that the second piece of this metric is about the EHR reporting, and that is a year away. Next slide, please. So other use cases. Well, I mean, my gosh, CCO metrics always seem to be the big one because there are high stakes associated with it. But what else? Clearly identifying individuals and populations with known community health need is super important. And one of the projects, I see Sarah on the call from OHSU, is heading up a project to associate clinical risk factors for hypertension, for diabetes, with identified social needs and be able to target those patients for intervention. That's really where we want to go from a population health standpoint. But from a data perspective, that requires us, A, to have actionable data on screening, which ain't easy, and two, be able to merge those data with clinical data around certain risk factors. So that's tough, but I think next to quality measures, that's kind of the most common use case that we see. Next, though, is being able to track requests. So kind of administratively, if you're going to create a referral for community services, it's been nice to be able to track those. And of course, the dream, even for medical referrals, is closed loop referral. And we're not there with medical referrals. We're so far away from that. So given that most community health, if not all, don't have an EHR, interoperability really isn't going to help us there. So we need to have other methods of keeping either one system up to date, which is sort of the dream of these CIEs for closed loop referral tracking, or use our EHRs to be able to track those, which may involve some manual steps and some work that the referral desks or the community health workers may not have on their list, is being able to essentially go in and track closure of requests for services. Bottom line, the CCO metric does not ask for confirmation of closure of services, and that was intentional. They're asking whether requests were made. So that's important. Ultimately, though, if you're going to put those requests in your EHR, being able to track whether they were completed does make sense, and that's not going to be easy. And then the final one that I thought of was use individual social needs to adjust risk, and we discussed that earlier. That's largely a payer function, and once again, this comes back to the clinics in having good quality coding that you're passing on to the payer to be able to mine those data. Other, so I'm very curious what types of other use cases you either do or would like to do that I haven't mentioned here that rely on social needs data in an EHR. So feel free to pop that in the chat. Next slide, please. Beyond EHRs. So again, each one of these could be a separate one, and there are many, many webinars on Unitas and the Community Information Exchange, which is called Community Connect, which is kind of the Oregon OHA branding of these CIE platforms. So if you're a clinic and you haven't heard of these platforms and you do network have CCO patients in your network, you're going to. So this is coming, and it is being pretty rapidly deployed across the state. I will say different CCOs have chosen certain options and have certain scopes when they deploy these tools. So again, your experience may vary as to whether screening is a part of that platform, whether closed loop referrals is going to be required, all those kinds of questions. Check with your CCO is the bottom line. Health information exchanges, I mentioned both Collective and Reliance. Reliance is kind of a good tool if it's active in your region and if your local providers are feeding it, which are both, there's variable coverage across the state. Reliance doesn't cover the entire state just yet, but if your common providers are feeding data to Reliance, building a alert for social needs could be helpful in these efforts. So moving away from using data retrospectively to a more proactive approach, which really I haven't talked much about today. We'll skip over interoperability because really that's EHR to EHR communication. And for social needs, that's really not terribly helpful at this point. Finally, another one that's super interesting to me is community level social health factors, which is knowing for a given zip code or a certain region code is what the level of poverty might be. And ARC put together, and I think this was kind of proof of concept was to put together a national database, and there's the link there. Unfortunately, it doesn't have many domains associated. Now, they were assuming that access to broadband and computing could be a proxy for poverty. So I don't know, that's one way to use it. But one use case might be combining external social data with what you have in your EHR at the individual or population health level and try to target geographic areas as opposed to targeting patients or patient cohorts. So, and I think this is something that's largely going to be coming, but we're probably a ways away from that. Next slide, please. Technical assistance, where can you go for help? I will mention, I kind of got really excited about putting Claire's name up here and listing the OHA sponsored TA. Keep in mind, this is for CCOs right now. So the initial CCO metric focus is on getting the CCOs and their network to build the infrastructure that they need to do this stuff. So the white paper that you see to the right is really geared towards the CCOs and not to individual clinics. I think the white paper is good stuff, and I would recommend that a clinic read that if your CCO is engaging you for help on this. Having said that, though, this technical assistance with the link there is actually geared towards the CCO. I imagine that OHA will create a technical assistance thread for clinics probably soon. And if somebody from OHA is on the call and you know if that's coming, feel free to chime in. That seems very sort of on brand for them to sort of add that to their portfolio, and I think it's probably coming. But in the absence of OHA TA, there's also OPCA, who I mentioned before, National Association of Community Health Centers, which partners with OPCA, and then Prepare, which seems to have kind of turned into its own organization. Originally, the NACHC had a lot of Prepare resources on their website, and I just checked it this week, and it looks like they've moved all those to the new Prepare website, which is represented here. So a lot of good stuff there, and I'm sure that specialty societies, and then a bunch of resources that I haven't even thought to mention. And again, in terms of academic literature, work done by Ochin and others, and I should mention OHSU and others, actually looking at the experiences that clinics have had, not only trying to do screening, but trying to use their EHRs to leverage to technology to assist the screening. And I am at time, and I did promise some Q&A, so I'm briefly scanning the chat. And I'm going to sneeze. One moment, please, I think. Nope. Yeah.
Awesome. Thank you so much. I want to give you a huge virtual round of applause, James. That was so great, and I learned so much. So we do have just a couple minutes left. So if anyone has any questions, now is a really good time for that. I'm going to stop sharing too.
James, this is Sarah from the Office of Rural Health, and I apologize if I missed this throughout your presentation. I was juggling a few things, but I'm wondering if you've gotten a preview of the social needs data that CMS is going to require in hospitals in 2024. And if so, do you think they're going to align with what the CCOs are requiring now for social needs data?
I haven't. And I know, and if OJ is on the call, they do a very good job of trying to align their metrics. But what I found is to OHA tends to be way ahead on a lot of things, like alcohol and drug risk screening. So I imagine that if they are not aligned, there will be a push to align them. Unfortunately, I have not reviewed the CMS. Unfortunately, my blinders are really around clinics and primary care. So I have not looked at those, but I will after this go and studiously look at those. That's my homework assignment for today.
Does anyone else have any questions with a couple minutes left?
Yeah, my name is Michelle Yank. I'm with Adventist Health Tillamook. And I apologize because I had an overlapping meeting and I missed 3/4 of this. So this might have been discussed, but it pertains to the utilization of community health workers to help stand up this whole infrastructure. And I want to use an analogy. Years ago, I wrote some grants for our local school district. We didn't have PE requirements and we didn't have funding for PE. And so PE went away in Tillamook County schools. Elementary schools, we had a whole generation of kids that did not have PE consistently, and their academic outcomes showed it. So the state understood the need to make sure that was mandated, and they offered an opportunity for non-competitive grant writing for 3 years of funding for PE teachers in schools in Oregon. And that created the bridge to the mandated point where those positions were expected to be covered by the district's budgets. So it's gotten me thinking about community health workers with this, because I don't think this is going to work if we don't have them, because you cannot be paying an RN to enter data to all of these systems. We've made the initiative to get this integrated. We're using Unitas right now, and we've integrated it into our Cerner electronic medical record system, but we still don't have the capacity to really screen and refer and monitor data. And that's just, to me, I just don't see it happening without that resource. So I'm just curious if there's any thought, or if anybody on this call at the state level might, be interested in considering something like that to help build that bridge. Thank you.
Yeah, I'll defer that. The unfunded mandate question. Yeah, it makes my teeth itch thinking of a busy clinician having to enter Z codes. And hopefully, it won't come to that, but.
Does anyone else have any questions?
Steffa, will there be any, I should have looked at the future webinars for this series. Are there any on policy?
Off the top of my head, no, but that is a really good idea. It's a great idea. Awesome. Well, thank you again, James. Another round of applause, and thank you everyone for joining us. Just a reminder, you can submit the survey for CEUs for this event, and please go to the website where you can find the recordings and slides for the events and register for the rest of the series. Thank you. Have a good day, everybody.
Thanks, everyone. Bye.
Thanks again. Bye.